Good morning, my name is Paola Ochoa, and I'm going to talk about balancing the risks and benefits of dual platelet inhibition. Definitions: cardiovascular and cerebrovascular events commonly arise from atherosclerotic plaque rupture that produces platelet activation, thrombus formation, and reduction of blood flow to the brain or heart. The inhibition of platelets with aspirin is effective in the secondary prevention of acute coronary events.
Hello, I'm Professor Robert Story from the University of Sheffield in the UK. It's my pleasure to be in Chieti to talk about the various aspects of platelet P2Y12 receptor antagonists. The P2Y12 receptor on platelets has proven to be a highly successful target on platelets in terms of therapeutics and prevention for arterial thrombosis. This relates to the unique role that P2Y12 receptor plays on platelets as an amplification system, amplifying thrombotic response, and also the inflammatory responses that go with that. Various trials have shown success for P2Y12 inhibitors, such as trials of ticagrelor, Plato study, that led to the introduction of ticagrelor's first-line therapy for acute coronary syndromes, Pegasus TIMI 54 study, demonstrating the benefits of continuing long-term ticagrelor therapy with aspirin. There's some issues about whether we should be taking aspirin in dual therapy, but we see a clear rationale for how that adds to the level of platelet inhibition with P2Y12 receptors. The P2Y12 on platelets plays a role in the vessel wall response to thrombosis. Some doubt as to whether platelets play a significant role in atherogenesis in its early stages, but clearly the thrombotic response to plaque rupture is driven by platelets, and the P2Y12 receptor plays a critical role in that. And this underpins the success of this therapeutic target.
Applications in medicine. The addition of clopidogrel, i.e. dual antiplatelet therapy, a platelet P2Y12 receptor antagonist, produces even greater secondary prevention of coronary events in high-risk patients for up to 1 year. Second-generation P2Y12 inhibitors, i.e. prasugrel and ticagrelor, produce further reductions in the risk of ischemic events over the same time frame, albeit with more bleeding complications. Dual antiplatelet therapy is recommended for 1 year after an acute coronary syndrome, but the effect of longer-term therapy is not clear. Concern exists regarding the balance between reducing the risk of cardiovascular events and the risk of bleeding complications, because bleeding complications are linked to adverse outcomes in patients with an acute coronary syndrome. Bonacca et al. In the prevention of cardiovascular events in patients with prior heart attack using ticagrelor compared with placebo on a background of aspirin thrombolysis in myocardial infarction 54, Pegasus TIMI 54 trial, provide insight into this balance in high-risk patients with a previous myocardial infarction.
The whole issue of what to do with patients who have high on-treatment platelet reactivity continues to baffle all of us caring for patients after PCI. Now in JACC is a report on the TRIGGER PCI study. This trial studied just such patients and evaluated the efficacy, safety, and antiplatelet effect of prasugrel as compared with clopidogrel. But practically, it gets to whether prasugrel can correct high on-treatment platelet reactivity and improve clinical outcomes in patients undergoing elective PCI. what they did. They took patients with high on-treatment platelet reactivity after PCI and randomized them together with prasugrel or clopidogrel. Platelet reactivity of the patients in the study drug was reassessed at 3 and 6 months. Now, importantly, the study was stopped prematurely for futility because of a lower than expected incidence of cardiac death or MI. But what the researchers found was that in patients assigned to prasugrel, platelet reactivity was decreased dramatically compared to those who continued on clopidogrel with a minimal cost of slightly increased bleeding. So what does this trial teach us? Switching from clopidogrel to prasugrel in patients with high on-treatment platelet reactivity results in effective platelet inhibition, no question. However, given the low rate of adverse ischemic events after PCI with contemporary drug-eluting stents in stable coronary disease, the clinical utility of this strategy could not be demonstrated. It is yet another example where the science seems sound, but we do not see a change in clinical events. I'm Peter Block, and this is a CardioSource Part 1.
Pros and cons. Pros. Doses of ticagrelor were associated with a 15% decrease in the rate of primary endpoint of death from cardiovascular causes, myocardial infarction or stroke. There was similar efficacy in the reduction of the rate of the primary endpoint with either ticagrelor dose, suggesting that the lower dose should be preferred in this patient population because it may limit clinically significant bleeding events. Long-term dual antiplatelet therapy produced a significant reduction, as compared with placebo, in the risk of ischemic cardiovascular events. Cons. Ticagrelor treatment also increased clinically significant bleeding complications by a factor of 2.3 to 2.6, and transfusions by a factor of 3 to 3.7. Long-term dual antiplatelet therapy increased by 1.56 times the rate of moderate or severe bleeding.
The design of the trial details the relative merit of competitor and targeted increased in patients who are not named. There's hashtag conclusion in whole spectrum ACS patients regarding 1-year clinical outcomes with missing. We therefore designed this investigator-initiated randomized multi-center open label. We enrolled a total of 4,018 patients and assigned them to either a circadian or target-based strategy. Primary endpoint was a targeted endpoint of death, myocardial infarction, and stroke at 1 year after randomization. We hypothesized that circadian would be superior to targeted regarding this endpoint, however, contrary to our expectation, we found that targeted was superior to importantly, this superior efficacy did not occur at the expense of an increased bleeding risk. Actually, bleeding risk was not increased with the target-based strategy. The trial not only compared two drugs, but also two strategies. That is, different loading strategies in non-acceleration treatments. Pre-treatment versus no pre-treatment. The COAST trial has shown that pre-treatment with primary and non-acceleration myocardial infarction increased bleeding but does not provide ischemic anti-ischemic benefit. Therefore, it is not recommended to pre-treat patients with targeted non-acceleration in mind. And this is also reflected in the current trial. So in non-acceleration treatment means patients randomized to targeted receive loading only after coronary artery repair, which is focused to PCI, whereas patients randomized to ticagrelor receive the loading dose as soon as possible. So in summary, the trial has shown that a drug-based strategy with no routine pre-treatment and non-FC elevation treatment in patients is superior to a ticagrelor-based strategy.
Issue apply inequality. Inequality ischemic heart diseases according to the latest study by the Ecuadorian Institute of Statistics and Census INEC of the year 2016 represents the first cause of death and has a prevalence of 10.15%. Acute coronary syndrome was the leading cause of death of the Ecuadorian population. Hence lies the importance of an early detection of symptoms in patients who go to an emergency system. Conclusion: high-risk patients with prior myocardial infarction are at risk for stroke, approximately one-third of which are fatal or lead to moderate to severe disability. The addition of ticagrelor 60 mg twice daily significantly reduced this risk without an excess of hemorrhagic stroke, but with more major bleeding. In high-risk patients with coronary disease, more intensive antiplatelet therapy should be considered not only to reduce the risk of coronary events, but also of stroke. Thank you.